Hi, this is Dr. Lavery, and I'm going to talk about gout today. What is gout? Gout's one of the most common type of inflammatory arthritis affecting 3 to 4% of the population. It's a condition where urate crystals or ammonium sodiate urate crystals come out of solution to form crystals when the uric acid is high. These crystals deposit in the joints and the tissues. The immune system then attacks the crystals to release inflammatory molecules that contribute to joint pain and inflammation. This deposition not only occurs in the joints, but can also occur in the bursts in the soft tissues. This is a cartoon demonstrating what is the chemical structure of uric acid, as well as what crystals of uric acid look like and where they deposit in the great toe. Now, how did it get its name? It came from the Latin and French root meaning drop. It's an old term meaning dropsy, where it was thought that the dropping of fluid and evil humors into a part of the body caused swelling. The first mention of podagra, another term for gout of the great toe, came about from a Dominican monk named Randolphus of Bocking, who lived in the 12th century. Now, what's the difference between gout and hyperuricemia? Gout is a medical condition characterized by abnormally high levels of uric acid in the blood that can be characterized by recurring attacks of joint inflammation, tophi, on and around joints, and the presence of kidney stones. Hyperuricemia, though, is the lab test in which there is a high level of uric acid in the blood caused by either overproduction of uric acid in the body or underelimination. It is when the serum uric acid is in excess of the solubility threshold of uric acid, which is about 7 milligrams per deciliter. That's the level at which uric acid crystals form when the blood becomes saturated. Now, the prevalence of gout is approximately 21.5% in men. In women, it's about 4.7%. The laboratory, though, may report a different level based on means. The prevalence of gout in men is about 5.9%, and in women, 2%. There is a lifetime risk of gout if there's hyperuricemia between 15 to 50%, depending on the level. Age-wise, it's relatively stable in men after puberty. It rises about 25% in women as they age, because estrogen promotes uric acid excretion in the kidney. So the sharp jump at menopause is because of less estrogen. Now, high uric acids and gout are prevalent in the population. Approximately 21.5% of adults in 2007, 2008 had elevated levels of uric acid without gout. 20% of these people will eventually develop gout in the future. The mean serum acid for the general population in 2008 was 5.48, but this is rising. Now, why is the uric acid level important? It's important because the higher levels you go beyond 7 milligrams per deciliter, the greater is your risk of an incidence of gout. Not prevalence, but incidence. That means new occurring cases. With urate levels greater than 9 milligrams per deciliter, there's a cumulative incidence of gout may reach 22% after 5 years. Comorbidities, other conditions that can exist with gout include hypertension, high blood pressure, chronic kidney disease, obesity, kidney stones, myocardial infarction, congestive heart failure, and previous strokes. Now, how's uric acid produced? Well, approximately 80% of the uric acid comes from breakdown of purines from cells. Cells in the body break down continually, and they become bases called adenine and guanine. When the cells get rid of this, the body then begins to convert these bases into other molecules, particularly hypoxanthine and xanthine. Xanthine is later broken down into uric acid, which then forms crystals. These breakdown steps are facilitated by the enzyme named xanthine oxidase, which is primarily in the liver. I should add that 20% of the body's uric acid also comes from the diet and can be increased with consuming foods rich in purines such as red meat, oily fish, alcohol, and beans. Now, why do we get hyperuricemia? Well, the reason why we get hyperuricemia is there's a certain amount of uric acid always in the body as muscles and tissues are constantly rejuvenating. The DNA in this tissue was broken down by the body, which later becomes uric acid. This is the amount. This amount is also contributed by the food that we eat that contains purine. Most of the uric acid is lost from the body through the kidneys and ends up in the urine. If everything's in balance, you lose as much uric acid as you produce and the uric acid levels become stable. Over time, our kidneys as we age are not as efficient at losing uric acid and levels begin to rise. As we get older, we tend to eat more food higher in content of purines. The end result is higher uric acid levels in our body. This is a cartoon describing the foods on the left that we eat. If the kidneys can't get rid of it as well as it should be, we end up having gout deposits in the joint. Now, what foods are high in purines? That would include sugary foods such as beverages, fructose corn syrup containing sodas, seafood, scallops, anchovies, herring, meat, sweet meats such as liver, vegetables such as peas, spinach, alcohol beverages, including beer. How do uric acid crystals form? Well, that occurs when the blood levels exceed 7 milligrams in the body, in joint, or in the blood. The fluid becomes saturated. Uric crystals precipitate as solution and deposit on the surface of the joint or into tissue. If there's too much uric acid level, they'll tend to precipitate to form uric crystals, mainly in joints of the toes, fingers, and knees and elbows, because that's what lower temperatures are, and a lower temperature doesn't allow much of the urate to be dissolved, so there is a greater incidence of crystal formation in these joints. Now, there's 3 stages of gout. The first is asymptomatic hyperuricemia, where the uric acid is high, but there's not been a gout episode. The second is intercritical gout, where there's an episode of acute gout separated by asymptomatic periods, which, left untreated, increases the possibility of having a second episode. And finally, there's chronic gout, where you have chronic deposits of uric acid crystals to form into a solid mass called a tophi, which I'll go into in a minute. Now, what is a gout attack? Basically, it's a monosodium urate crystal that comes out of solution and deposited in the joints. Once the urate crystals are inside the joints, phagocytes or neutrophils begin to engulf those crystals and release inflammatory molecules that cause pain and swelling of that joint. How long does a gout attack last? Well, a gout attack will last between 3 days to 3 weeks. However, most gout attacks last fewer than 10 days. Once the neutrophils or white cells digest the uric acid crystals, they tend to die off, ending the attack. Here's another cartoon that pictures the uric acid crystals and how they deposit on the joint and cause inflammation. Now, the triggers of gout will include trauma and surgery. That's mainly because trauma will begin in the setting of microtrauma. Uric acid crystals will start to fluff off and go into the solution and contribute and trigger the immune system. There's also starvation with more breaking down of tissues, fatty foods, dietary overindulgence, dehydration where there's less free water to urine production, drugs that can increase the serum uric acid. There's beer and spirits, but not wine, high levels of meat and seafood consumption. Joint involvement in gout can present in one joint such as the toe or knees. It can also occur in the elbows, Achilles tendon, and ears. Older patients may present atypically with attacks in the fingers. Acute flares of gout may increase in frequency and duration and lead to chronic gout. Chronic gout may be polyarticular with the involvement of multiple joints. These attacks may be less intense, but not always prompting acute care. Here's an example of gout hitting a finger. Here it is in a toe. You'll notice on the right there's a secretion or a liquidy substance which is filled with uric acid crystals. It can also occur in the ears. Now, urate deposition chronic gout is a definition where urate deposition takes in and around joint with a mean, usually with a mean serum acid about 6.8 over a period of several years. The clinical features include an acute intermittent inflammatory arthritis, tophi, joint pain and swelling due to inflammation of the cartilage, and bursitis and tendinitis. Now, what is a tophi? What are tophi? Tophi are chunks of uric acid crystals that accumulate in and around the joints and other parts of the body as a result of advanced gout. Tophi surrounding gout can cause that joint to become swollen and misshapen, and the skin that covers it to become stretched and taut, sometimes to the point of ulceration. Tophi can erode bone and destroy cartilage, leading to chronic inflammation that can be painful and debilitating. Tophus is typically easy to identify with a visual exam, but sometimes imaging and aspiration may be necessary to confirm a diagnosis. Depending on the size and location of the tophi, it can be dissolved with medication that lowers the levels of uric acid in the blood, or if it's very large, need to be surgically removed. Approximately 12 to 35% of people with gout have tophi. Here's an example of tophi in the left elbow and on the knuckle. How to diagnose gout? Well, we first try to aspirate a joint and find urate crystals in the joint fluid. We can also do x-rays, but this usually only occurs in long-standing disease. Ultrasound can be useful. If we find definite tophi on physical examination, a biopsy may be helpful. Some authorities include the typical case of acute gout of one joint, such as the great toe, as diagnostic. Serum uric acid levels are not always helpful for diagnosis, since uric acid levels may be normal with acute attacks. But how is that possible? Well, it is possible that at times gout may occur, a gouty attack may occur as a result of crystals in the tissue as opposed to being in the blood. This is an aspiration of a bursae at the elbow. You'll notice a chalky white substance comes out. We send this down to the lab, and these crystals are usually needle-shaped, and they can occur both in the cell and outside the cell. They may occur also outside the cell or within tophi. An important diagnostic procedure for the clinical diagnosis of gout is to examine the synovial fluid under polarized light microscopies. What usually happens is we use a polarizer, and there's a compensator with that, and when the needles are parallel to the compensator, they look yellow, and when they're not perpendicular, they look blue. What a polarizing microscope is that there's two polarizers, one between the light source and the examination, which converts unpolarized light into plane or turns in light going in one direction. The second, which can be rotated, is positioned between the eyepiece and the sample. We also use a first order red compensation in the light path between a polarizer and analyzer. The field becomes rose colored. That means the background turns red. And as we turn the compensator, the crystal can become either yellow or blue. Under a polarizing light microscopy, urate crystals appear yellow when aligned parallel to the axis of the red compensator, and blue when aligned across the direction of polarizing, which means they exhibit negative birefringence. In other words, negative birefringence is when polarized light, which is going in one direction, hits a crystal. It can go in two directions. If it's not, then it appears to be yellow, and when it is, it turns to be blue. Conventional radiography or x-rays may be normal in early stages. Chronic gout features with x-rays include the tophi, the uric acid crystals, the joint space narrowing, the erosions, osteopenia, and uric acid deposition. This is an example of gout where we have erosions of the knuckles, of the finger joints as well as tophi. There's wearing away of the bones. Ultrasound can be useful because we can find joint fluid with spots suggestive of urate crystals. There can be increased cartilage thinking, bone erosions. There could be a double contour sign in tophi. This is a double contour sign, which is a white band on top of the cartilage. This sign can also be found in acute flare-ups and can be sometimes found in clinically uninvolved joints. That means you could have a hyperuricemia without symptoms, and you may be able to find this. One problem with this is if the uric acid levels are controlled to less than 6 after 7 months, it may disappear. This is a picture of a tophi with white calcifications within it. We also use dual energy CT, which is basically the ability to discern tissues based on their density and atomic number. It can help detect damage, but not inflammation. It is one of the better superior techniques we have. This is a picture of it where the red shows we're having deposits. Unfortunately, that is not available here in this area. Now, treating gout, we treat the inflammation that occurs with gout with the activation of the immune system with gout crystals, or we lower the uric acid with urate lowering therapy to prevent the substrate and environment for crystal formation. The goals for treating gout is to lower the incidence of gout flares and joint damage, dissolve tophi, and prevent complications of gout, such as kidney stone and destructive arthritis. Acute gout treatment usually consists of steroids. Whether we inject them, we take them by mouth, give them IV, or we can use colchicine, which is an anti-inflammatory. In the acute phase, we don't use more than 2.5 milligrams in 24 hours. Regularly, on a chronic basis, not more than 0.6 milligrams twice a day. We can also use non-steroidals. There's no difference between what agents we use. Colchicine comes from the crocus plant. In Greece, it was used as a purgative. It's been used for over 1,500 years for gout treatment. It's mostly useful during the first 48 hours of a gout attack and acts like an anti-inflammatory. It may be given to help prevent gout flares for up to 3 to 6 months while we use urate lowering therapy, and I'll get into that in a minute. It has to be used with caution because it does interact with other medications. Side effects may include neuropathy and myopathy. Blood counts and kidney function should be monitored on a regular basis due to potential lower white blood counts and platelets. Now, the second part of treating gout is to lower the uric acid level with urate lowering therapy. We have medications that lower the uric acid production. We have medications that increase the excretion of urate into the kidney, and we have medications that convert it into something else. This is a diagram that pictures the various methods that we use to lower gout. On the left, you'll see there's xanthine inhibitors. They work on to block an enzyme called xanthine oxidase. On the left-hand side, there's euchosurics, which means we get rid of urine. That's called probenecid. And then on the upper right, we use something called plegotacase or Cristexa, which is a replacement enzyme with uricase that breaks down the uric acid into allopurinol. Now, the indications for using urate lowering therapy are tophi, frequent attacks of gout more than 2 per year, chronic kidney disease of stage 2 or worse, and past history of kidney stones. Now, gout treatment, we usually will have to commit this person to a lifelong treatment. We do not treat with the first attack. We usually wait till there's 2 attacks a year. We continue with a dose that will achieve the desired uric acid level, which is approximately 6. That's the level at which we can get dissolution of crystals, possibly tophi. If possible, we get it down to 5. All urate lowering therapy increases the risk of a gout attack when you start taking it, so we have to give something to prevent attacks, and we usually use that with non-steroidals or colchicine and try to continue it for 3 to 6 months. We don't give urate lowering therapies during acute attack because a lot of them, most all urate lowering therapies initially will make precipitate acute attack. First one, the most recommended one for price and utility is Allopurinol. It's the preferred list treatment. It's usually considered at starting doses less than 100 per day, possibly 50. The maximum, we try to increase the dose in increments of 50 to 100 milligrams per day, maximum dose being 800 milligrams. I should add that the usual average dose out there is about 300 milligrams, and that doesn't always obtain, we don't always obtain a lower uric acid with that. One of the downfalls of allopurinol is we have to be careful about skin reactions. Approximately 2 to 4% of people who start out can have this. The risk factors for that would be recent use, allopurinol for asymptomatic hyperuricemia, female gender with a history of skin reaction to allopurinol, and an HALB5 carriage, which is something we check when, in Asians and African Americans because they may be at a greater risk. I should add, we do not treat asymptomatic hyperuricemia because not all of them go on to have gout attacks. As I mentioned, there is a risk of an incidental increase of 20%, but you leave 80% that do not have gout and have high uric acid levels. Why do we get gout flares after using allopurinol? As you lower the uric acid in the blood, you have an increased risk of gout flares because what you're doing is you're dissolving the crystals. The crystals become more fragile and they shed into the joint space and trigger inflammation by exposure to neutrophils. Here's another schematic. I'm going to work on the left part, which is renal excretion. And what we try to do is to promote the excretion of uric acid, urates into the urine. We do that with probenecid, which inhibits urate reabsorption. That means the urine, when urine and blood go through the kidney, this prevents the reabsorption back into the blood. Instead, pushes it into the urine. It competes with the drug itself, competes with urate, with a urate transporter in the cell. It blocks reabsorption, increases excretion. Thus, it lowers the amount of urate in the blood. We don't use it with a history of kidney stones. If someone has a glomerular filtration rate less than 50, we try to avoid it. You can get blood abnormalities, but it has been used with xanthase inhibitors for refractory cases. There is another eucosoric called lesinurad. This is similar to probenecid. The problem with that is that elevations of kidney function have been observed, and we have to keep our eye on that. Finally, we have uricase, pegloticase. That is a enzyme that humans lack, so we give it intravenously. It's capable of metabolizing, turning uric acid into a much soluble allopurinol, which allows better secretion. It's much more soluble so the body can get rid of it. It's extremely effective for reducing uric acid, depressing levels less than 1 milligrams per deciliter in treated patients. That allows the rapid dissolution of tophi and significant improvement in function after long-term dosing. It is an IV infusion. It's indicated for refractory gout with high disease burden. Because it is a foreign protein, there's a risk of infusion reaction. The risk of infusion reaction increases if the serum uric acid is rising. So we check the uric acid prior to each infusion. If it's above 6 milliliters per deciliter, we don't use it. We're not to use it in a certain glucose 6-phosphate deficiency because it can result in hemolytic anemia. Is gout hereditary? Well, from Taiwan in 2004, it was shown from the National Health Insurance Database that individuals who have first-degree relatives, such as a parent or sibling, are on average 3 times more likely to develop gout. Individuals with an affected parent are twice as likely to develop gout, and individuals with a twin are 8 times more likely to develop gout. But you have to keep in mind that dietary habits can follow family members. It's recommended recently by the American College of Rheumatology that we pursue lifestyle management. That means to limit the intake of alcohol and purine and high fructose corn sugar, and we pursue weight loss. It was noted that mean body mass index of greater than 5% can be associated in people with gout with higher odds of a recurrent flare, and a decrease has the opposite effect with less flares. Alcohol, if possible, should be limited or abstained because it can raise uric acid levels. It's been found in a crossover study where people received treatment in a random order had a 40% higher risk of gout flares without alcohol consumption. We also have to look at other medications the patient's on. We try to avoid hydrochlorothiazide, and we'll look to other types of high blood pressure medicines. Losartan, an angiotensin receptor blocker, has been recommended because that is lowers uric acid levels. We also, for people who have need to be on cholesterol lowering therapy, we're recommending fenofibrate for the same reason. The American College of Rheumatology has recommended against stopping low-dose aspirin. I should add that with allopurinol, testing for this gene should be done in patients of African American descent as well as Eastern Asian because they may be at a greater risk for skin reactions. What about cherry juice? Well, in a 12-week placebo-controlled study, cherry juice was found to decrease serum uric acid level by 19.2% in overweight and obese individuals. That's because they contain anthocyanins, which are type of flavonoid, which has antioxidant effects. And these are also found in berries, red onions, kidney beans, pomegranates, grapes, bilberry, chokeberry, elderberry, and tart cherries. The studies were done with 8 ounces of diluted soft cherry juice twice a day for 2 to 4 weeks. But experts have recommended drinking 1 glass of tart cherry juice for gout per day. Cherry juice actually blocks the tubular absorption, reabsorption of urate, increases urate excretion in the urine, as well as blocks anthine oxidation, reduces the production of uric acid. Final points. We're here at the end. Gout is a chronic disease with a multifactorial pathogenesis. Recurrent attacks of gout may lead to bad chronic disease. For acute attacks, we address the inflammation that occurs in response to uric acid crystal deposition by the immune system. These modalities may be continued for months as uric acid levels decrease. Since uric acid levels increase the risk of gout, therapies to lower uric acid should be instituted to lower the level of uric acid below the goal of 6. These include allopurinol, febuxostat, which I forgot to mention is also called Uric, which is similar to allopurinol, probenecid, and pegloticase. Lifestyle measures such as less alcohol and sugar and weight loss may make a difference. Thank you.